All right. So we're going to go ahead and get started. Thank you, everyone, for being here today. We find in our rubbery that you take the time to come and spend time with DMAS and learning a little bit more about the programs and opportunity services offered through Virginia Medicaid, wherever that may land. And so if you can please go to the next slide. I do want to thank all of the team for helping to pull this together. There's three of us on comment that help facilitate this, as well as we have some technology support. And then our administrators that help with this as well. So I want to take the time to thank everyone. This is not an easy feat to do every other month, essentially. And so taking the time to really acknowledge those team members who do a lot of time and effort in creating space and creating opportunity for us to have dialogue. So I really want to thank them for that. Particularly at this season when we're very grateful for all the work and support that we get through our teammates. And so today, if you can go to the next slide, please, Dahlia. We have welcome and introductions, and then we're going to go through our presentations. Oh, we're missing one. Our community, the last one, which is our community spotlight, which allows for us to really talk about all the wins that we've had this year, or just how engaging with Virginia Medicaid has helped you in the work that you do. And so we want to create space for that. All right, so we'll have first introductions by our speakers, and then we'll go to the next slide, please. All right, so if you can give your name, what position you hold. I know you, for our speakers, you're at DMAS, so we know that. And then what is your favorite Christmas movie? So I'll start off. So my name is Natalie Pennywell. I am the Community Outreach and Member Engagement Manager. Manager. Work for DMAS. And my favorite Christmas movie right now is This Christmas, because it is full of complete and utter shenanigans. I love it so much. I will say as a runner-up is Christmas Vacation, because my aunt watches it every single year. Every year she watches it, and it is the best time watching her watch that movie, like she has seen it for the first time. So I love it ever since. So I'm going to pass it over to Lisa.
Everybody, I'm Lisa Jobe Shields. I'm the Behavioral Health Division Director here at DMAS. And I'm going to have to go with Elf as my current favorite Christmas movie. I recently introduced my kids to it, and they didn't love it quite as much as I did, but they thought it was pretty funny.
Aaron. Oh, you're on mute, Aaron. We can't hear you. No. Oh, he was having some sound issues.
Right. Can you hear me?
There we go. We can hear you now.
Okay. Well, my name is Aaron Moore. I'm the Transportation Management Services Unit Manager here at DMAS. And my favorite, you guys are going to think I'm nerdy, my favorite Christmas movie is actually Jouy Noel, and I love history, and it's about what they call the Christmas miracle, the peace that happened during World War I on Christmas night between the fighting sides. So.
I love that. Now, I will say that it takes a lot for me to watch the Christmas. Is it the Christmas? Well, like, yeah. So it's okay though. It comes every few years. I could do it. So we have please, if you are here as a guest, please drop your name, position, organization, and please answer the question in the chat. We want to make sure. I see Amanda said that her favorite is A Christmas Story. How can you not love A Christmas Story? And they play A Christmas Story, I think, for like 24 hours straight on TNT or something like that on Christmas Day. I mean, how many times you can watch that tongue get stuck, I don't know, but still, it seems like a wonderful opportunity. Emily says Elf, so you have a partner in crime there, Lisa. And I'm sure some other people will comment throughout. And the Polar Express, Polar Express is a wonderful one. It's a Wonderful Life. And I will tell you, I took my nephews on a Polar Express ride that they have actually in the mountains of North Carolina. They kind of recreate it. They do hot chocolate, they dance in the aisle, they do all the stuff. So if you're ever interested in that for your kids, it is a wonderful activity. My nephews loved it so much. All right, so keep them coming. Please introduce yourselves and please drop in your favorite Christmas movie. All right, next slide, please. All right, so we're going to pass it over to Lisa, and then we'll go from here.
All right, thank you so much, Natalie, and thank you, everybody. It's great to see folks joining, and I'm just going to give a brief presentation today highlighting a change happening with some of our behavioral health services, and then otherwise really trying to just provide a general overview of the different services that we have out there, what they're like, and how to access them, and happy to take any questions as needed. We can go ahead. So, yep, just like that, we do have an update regarding crisis services, and we'll talk a little bit about youth, adults, and then our arts benefit, which is our substance use benefit. Okay, next slide. So this is just sort of how we've been highlighting our services now. We always like to tie it into Governor Youngkin's Right Help Right Now plan, which is essentially a plan to continue the transformation of behavioral health services in Virginia. And there's 6 pillars. And 2 of these are actually related to crisis services. So that's kind of the nexus of why we're making some of these changes to crisis services and why we're making them right now. The goal really being that any Virginian, when they're experiencing a behavioral health crisis, so that's not just Medicaid members, but any Virginian has a way to access the right level of care, immediately then when they need it. And you can go ahead to the next slide. And so one of the main ways that it impacts our crisis services. So in Medicaid, we prior to maybe around, we'll say right around then, right, December 2020, 2021, historically there were 2 crisis services in Medicaid that kind of filled a lot of gaps in the system. But as of December 2021, we implemented 4 different crisis services as the crisis array in Medicaid. And we're using a national best practice model called the Crisis Now model, which essentially focuses on making sure that someone has someone to call, someone to respond in the community, and then also a place to go if needed. So a safe place to go. And so there's 4 services that have been in place under Medicaid since about that time. And since then, our sister agency, DBHDS, which through the Code of Virginia is empowered to really build up our state crisis system. They manage the 988 tax. I don't know if that's something that you noticed. It's actually been in place for about 18 months as well. A small cell phone tax has been added to all cell phones in Virginia, so that this 3-digit number 988 can be used across the board to access crisis services during a mental health crisis. And so they've been building that infrastructure. They've been working on it. We've been partnering really ever since our services came online. All Medicaid providers of crisis services have had to be under a memorandum of understanding with the mobile crisis hubs, and they've also been required to use the data platform. But beginning December 15th, it's really reaching the next level of coordination, and all mobile crisis response. So that's one of the 4 crisis services. That's the one that comes out to you within an hour of the crisis occurring. That service is now going to be fully dispatched through the 988 call centers and the regional mobile crisis hubs. So that's going to be a big change, but ultimately it's all part of the Crisis Now model and the idea of anyone should be able to reach out and have access to that service within an hour. You can go to the next slide. I think I have one more crisis slide. Yep, so this is just a little bit more information about those services. Again, the only one that's changing is how mobile crisis response is dispatched. It's actually not a Medicaid policy change because again, it's all sort of in the agreements between the providers and the mobile crisis hubs, but it will in practice be a pretty big change as far as this service being dispatched. Briefly, I wanted to go over the other ones. The next one in our array is community stabilization. This is actually our Virginia specific service. The Crisis Now model has the other 3 services, but when this benefit was being built, a lot of stakeholders pretty much were saying that if you don't have something that can kind of fill the gap between the initial mobile crisis response and longer term, outpatient or even higher level of care service, if you don't have something that's going to kind of fill that gap, you're kind of going to leave people hanging when they're having a crisis. And so we built a 4th service into the Medicaid benefit, and it's called community stabilization. So it's a little bit longer. oftentimes. So it does require prior authorization through the managed care companies, but they'll often approve things like, 7 days, 14 days, essentially that bridge service to get them to that next level of care. 23-hour crisis stabilization and residential crisis stabilization, these are the two place-based services. So these are actually a place where you would go. 23-hour crisis stabilization is the arrangement looks very much like an armchair. There's nursing staff, peer recovery specialists, clinicians, all sorts of staff there to essentially kind of see what's going on during those first 23 hours, so that if people just, again, need a little bit more than a mobile crisis visit, but it's unclear whether they need something like going to an inpatient level of care, it provides that 23 hours of just, crisis intervention, support, care coordination, and it's paid on a per diem for those 23 up to 23 hours. And then finally, residential crisis stabilization. This is when someone needs a longer term stay, multiple nights, overnight, at a residential crisis stabilization unit. But again, still a community-based service. It's not an inpatient stay, but it is, very much a higher level of crisis care. So those are the 4 services. Again, this change only impacts how mobile crisis response is dispatched, but it will be a significant change to the system. All right, we can go ahead. This is just one other kind of depiction that we've been liking to share in terms of, really when we're communicating also with providers and families and anyone going through a crisis, just acknowledging that, even as we set up these teams to respond out in the hour, we do understand that crisis and kind of figuring out what's going on during a crisis, figuring out exactly what a family needs, what Medicaid services, what non-Medicaid services, what social supports are needed. It's really complicated, and it's going to take us time to build this system. It's not just about kind of what's going on with the family. It also has to do with the preferences of the individual or the family, the resources that they have, whether there's services available in their community, and it is really complicated, and we do acknowledge that, and we think that our services are providing a big benefit, and are really adding something to our benefit, but we know there's also a lot of work to do to really get it right. So we do welcome feedback across the board when it comes to what do individuals, members, and families need when they're experiencing a crisis. All right, next slide. All right, so then I just have one slide on the youth and one on the adults, just to kind of show where our continuum is at right now. At the top of the continuum, we have a range of what we might call non-specialized behavioral health services. So these are things like, getting therapy, getting medication management. None of these require a prior authorization. Any member, we know that it can be hard to access services, so you might need support to get that care coordination and find a therapist. But in terms of needing any type of authorization, that's never needed for our, non-specialty outpatient services. As you then get a little higher, we do have intensive community-based services and intensive clinic-based services. And for youth, the intensive community services we have, there's 4 of them. 2 of them are our older legacy services, intensive in-home services, and therapeutic day treatment. And then 2 are newer evidence-based services that they don't reach everybody. They're for a pretty specific group. They're for teenagers, so starting around 11 or 12, going through 17 or 18. And they're for teenagers that are struggling with behavior problems, substance use, mood disorders. It's really like pretty intensive wraparound services for the whole family. So 2 really great evidence-based models. Again, they can't meet the needs of everybody because they're pretty prescribed, but they're the type we'd like to bring even more models like that to the benefit. Then on the intensive clinic-based side, we have intensive outpatient and partial hospitalization. This is a new level of care within the last 2 years. We've already talked about comprehensive crisis services. And on the youth side, we do have residential services. So these are accessed through a pretty intensive assessment process, but they are part of the Medicaid plan for youth. When we get to the adults, you'll see that that's not the case, but we do have that residential level of care for youth when it's needed. And then, of course, at the highest level are those inpatient services. So that's sort of our youth benefit. Again, we There's still a lot of work to do to build it out to have what you would call a full continuum. But we do feel that we're starting to see some of that kind of lower level, easy to access services, some more middle range services, and then those high end services there. So you can go ahead to the adult slide, and I've just got a few minutes left. And so then same thing, this is our continuum on the adult side. You'll see the arts services are all there on the right, but I'm going to cover them all at the end. So same thing on the adult side, we have outpatient services, psychiatry and psychotherapy, as well as peer recovery support services can all be accessed without any type of authorization. And then we have these more intensive community supports. Right now we have 3 intensive community supports for adults. 2 are services that have been around for a long time, mental health skill building and psychosocial rehab. These are both for adults with serious mental illness, supporting the, learning any type of skills that are needed to build relationships and seek employment and all of that. And then our highest intensive community support right now is called assertive community treatment. This is it's really intensive service. Some people actually call it the hospital without walls. The team is multidisciplinary team. They are in your house every day, typically not every day, based on the care need, but it can be every day, bringing the resources that are needed so that folks can thrive in their homes and in their communities. But again, it is an evidence-based model, so it can't meet all the needs. It's for very specific diagnoses. It's for schizophrenia, severe mood disorders, including bipolar disorder, as well as major depression. And sometimes can be used for other conditions, but that's the primary grouping. Also for adults, we have the intensive clinic-based, so intensive outpatient and partial hospitalization, the crisis services we've already talked about. But then when it comes to residential, we do not have any mental health residential services in our benefit currently for adults. We do on the substance use side, which I'll talk about on the next slide. So we are able to meet that need, but then of course there's inpatient hospitalization. So still we have work to do to build out some more services on the adult side, but this is where our benefit is currently. And final slide, you can go ahead. So sort of on both the youth and the adult side, we have what we call our arts benefit, addiction recovery treatment services. And this is really the full array from outpatient all the way to medically managed inpatient detox services. And these can be used for youth and adults as needed. Year over year, we continue to see more members accessing these services with over 50,000 at this point. And this is all part of what's called an 1115 waiver authority. You have to have special permission from CMS to build that residential level of care for adults when you're going to have any type of situation with more than 16 beds. And so that's something that we do have on the substance use side. And we think it's providing, a huge benefit to the community and serving a lot of members that need to be in that residential level of care for a while while they're getting their treatment. And that's something that, ultimately we would probably like to see on the mental health side too. And that waiver is up for renewal. I say this December, it's actually kind of next December. So we have about a year to get that renewed, but we're seeking to renew that because we want these services outside of the residential. These are all written into the state plan. These services are here to stay in Medicaid, but we would like to get the waiver for another 5 years as well. So that's what I brought to share. I hope that was some of that information was relevant. And I don't know if we're going to wait. I'm happy to stay on or do questions now, whatever makes sense. Thank you, Natalie.
No worries. And so oftentimes we'll have questions that pop up to us. If you can stick around to the end, that'd be wonderful. Just as an initial question, we have the number, the 988 number, and that is like the first step if somebody's going through a crisis. You have so many of our members that don't quite understand nor know how to navigate these services and their family members that are supporting them. Outside of taking that initial step, what are some other things that stakeholders can do to support this help right now and any initiative regarding behavioral health or mental health services?
Yeah, that's a great point. Yes, I think working to have people understand accessing 988 and providers helping clients access it. Providers work sitting right with clients and helping them access it, I think is a great way to do it. And then each hub, so each regional hub has kind of its own processes and different ways that, they'll probably be working with providers and kind of, different, there's like an example would be the Marcus Alert. So sort of how they're working with community partners there, it's not, they have different phone numbers and different ways that they can connect. So I think really talking to the mobile crisis hubs is a huge part of it, sharing that number. And then also continuing to provide, so many of our other services have a crisis intervention component. And so just continuing to bring more and more providers to do those services, so really getting the word out of, we might not have all the services in the world, but we do have a lot of new services. And so, I'm really trying to get anyone who's interested in becoming a Medicaid provider to really think about it, really think about the whole continuum and see where they might fit in, so that we can have more and more community-based providers across the state, especially in areas where there aren't as many providers. So continuing to just kind of spread the word of, hey, there might be more opportunities in Medicaid. Have you looked at them lately to see what's out there? Because so that members can get the services they need, we really just have to have that strong network. So that's one thing that I'll put out there. Thank you.
Thank you. Always looking for additional champions for this work, right? And so, all right, so we're going to switch over to Aaron. And so if Aaron can introduce himself, and then we'll go from there. Thanks, Aaron.
Can you all hear me? Just double checking with my audio. Okay.
Yes, we can hear you.
Good. My name's Aaron Moore, and I'm the Transportation Management Services Unit Manager here at DMAS. That's kind of a mouthful. But essentially what I do is oversee the fee-for-service, NEMT, or non-emergency medical transportation program, and work with the managed care organizations to provide guidance for their non-emergency medical transportation programs. I'll get into that in a little more detail during the slide, but just sort of to enhance and ensure consistency and stability throughout the programs in the state. Next slide. So just to give you a little idea of the structure of our unit, there's myself, the TMSU manager. I have a TMSU supervisor, office supervisor, and field monitor supervisor named Joey Miller. He oversees most of the staff. We have the fee-for-service NEMT contract manager, and she oversees the broker. That's Nikki Taylor. We have a contract monitor. We're currently in process of hiring, and they will help and assist Nikki in overseeing the contract for the broker. And I'll talk about a broker later. And we have the senior program support technician who does a lot of customer service work. She also assists with in-state and out-of-state transportation, looking for overnight transports, etc. And her name is Charlotte Bennett. And then we have our field monitors. And on the next slide, I'll show you who the field monitors are for the different regions in Virginia. So our field monitors are sort of separated out through the different regions in Virginia. We have Chuck Hallman in Region 1. Now, all of these field monitors, essentially what they do is help our contract manager and contract monitor overseeing all the transportation providers that are under the different brokers and making sure that they have safe vehicles and making sure that their drivers are all appropriately credentialed and have received all the appropriate trainings to transport Medicaid members. We have Tina Davis in Region 2. My favorite field monitor, and I always tease him, he drew the short straw, is David Affey, and he's got 3 regions. Now that's because they're smaller regions and they're all right next to each other, but it just sort of, it doesn't ring true for a lot of people. They're like, wait, how come he has 3 regions? So, and then we have Dee Dee Jones in Region 6. Now on the next slide, it gives you a sort of a sense of where we're looking at by region. So Region 1 is the Tidewater region over there in the black, outlined in black on the right side of this, well, my right side of the screen. Region 2 is the central area, sort of outlined in that aqua kind of blue. Region 6 is the slightly dark green region sort of there, and that's in the northern West Winchester region. And then regions 3, 4, and 5 that my friend David Haffey has are sort of consecutively out there towards the left, but the Western and Charlottesville, the Roanoke, Allegheny, and the Southwest regions for Virginia. Next slide. So just as an introduction, just to make sure everybody understands what I mean when I talk about the non-emergency medical transportation. Non-emergency medical transportation is a Medicaid benefit for a majority of the fee-for-service members and managed care organization members. And essentially, it's a service that transports individuals to Medicaid-approved services, appointments, et cetera, if they don't have other transportation that they can otherwise use or rely on. Now, the managed care organizations have additional benefits beyond simply the Medicaid-covered services, so they allow members to go to places that are in line with a quality of life, such as going to the grocery store, attending places of worship, going to the DMV, etc. Fee-for-service is limited only to Medicaid-approved services. Now, with the fee-for-service and the 6 MCOs, each of them have an NEMT transportation broker. And just so you all know what a transportation broker is essentially an organization that finds NEMT providers, coordinates with the member need for transportation once the member need comes in on a call, and then assigns or dispatches the different NEMT providers in accordance with the level of service needed and the transport needed by each member. So brokers can and do have several contracts, like they'll share some. For instance, and I'll get to this in a later slide, but Motive Care as a broker and Verida have multiple contracts for the different managed care organizations. And Motive Care even does the fee-for-service brokerage. So with all of that, Virginia has 7 statewide NEMT programs, which is why I think it's very important to give this kind of education, just so that way it helps members, stakeholders, family members, et cetera, sort of navigate the transportation network. Non-emergency medical transportation in the name is not for emergencies. It's not emergency transportation. So for that, members still need to dial 911 for emergency services. There are actual variations to the NEMT programs, but DMAS has worked to provide guidance and policy to all the MCOs as well as for the fee-for-service, just to make sure that there's consistency with the programs throughout. Next slide. So just as an introduction to the types of non-emergency medical service, so there's ambulatory, which means the members are able to sort of ambulate and transport themselves to and from the vehicle. And typically for the ambulatory services, we include taxis, transportation network companies, or TNCs, and these are Uber, Lyft, Wings, those kinds of services, and then volunteer drivers. We have the wheelchair van, which is fairly prevalent, but it's a van type service that accommodates mobility devices for members who are dependent on those in order to navigate to and from services. We have van stretcher, and the difference between van stretcher and stretcher non-emergency ambulance is that with van stretcher, the members need to be transported by stretcher, but they don't require medical care or monitoring while they're being transported, whereas we have stretcher, which is an ambulance essentially, non-emergency ambulance, and that the members do need to have medical care provided, as like for instance oxygen being provided, and they require monitoring while they're being transported. Generally, these kinds of services are used between healthcare facilities. We have our gas reimbursement program, where family members and friends can actually receive reimbursement for traveling to or taking a family member to Medicaid covered services. And then some instances where the member happens to live in an area where there's public transit available and the transit lines take them to Medicaid covered services, bus tickets are sometimes distributed by the NEMT brokers. Next slide. So this is just provides a visual kind of what I was talking about earlier with respect to the fee-for-service and managed care organization NEMT programs. So I have the MCOs as well as the fee-for-service and the associated broker listed in the colors there. So there's Anthem as the MCO and Access to Care is their broker. Optima and Virginia Premier have Verida, formerly Southeast Trans, as their broker. And then fee-for-service, Aetna, United Healthcare, and pretty soon they're transitioning from Verida, Optima, and Virginia Premier pretty soon, starting January 1st, will all be with Motive Care. And then Molina, which was formerly Magellan, it has MTM as their broker. And the graphic there just kind of gives you the visualization of the brokers up at the top, receives the member transport, and then distributes out to the various providers depending on the level of care needed and the level of assistance. Next slide. So just to give some stats and some metrics associated with the NEMT program. So DMAS serves about 2.16 million Medicaid members. This is as of, I believe, as of October. I need to update it for the November numbers. And then includes about 729,000 Medicaid expansion members, a little over. The ID and DD waivered NEMT services has the community living waiver, so about 11,000 of the CL waiver members receiving NEMT transport. We have our building independence waiver with about a little over 300 members, and our family and individual support waiver with about a little over 4,000 members receiving a transportation benefit. The MCO NEMT programs that transport ID and DD waivered members, they do that to their acute care services. And as I mentioned before, we have 7 Virginia NEMT programs. The fee-for-service NEMT program serves about an average population of about 128,000, sometimes up to 130, depending on the waivers. They tend to fluctuate and attrition. And then we have 6 managed care organizations with their brokers as well. So, next slide. It's a little hard to see, but these are sort of the metrics as I had mentioned before, but you can kind of see there. We do keep track of the metrics and the total number of individuals by contract year and by eligibility category. We like to track this just to make sure we can see any trends that are going on and make accommodations with the transportation broker in order to meet or address trends amongst the members and the member population. Next slide. Also here, just again, keeping track of the average number of unduplicated riders for the fee-for-service NEMT program. That's just to make sure we're keeping track of how many individuals are regularly using the service and how many are using it on a regular basis when we look at the number of trips we have total. And that's one of those metrics we track in order to make sure we have enough providers in the provider network to accommodate the trips that we see. We usually have about 7 million trips per annum that we transport. So next slide. As you can see here, there's like gross trips have gone down since COVID, but we're actually getting back up to where we used to be, but they were severely impacted by the pandemic. And so we lost about 96 NEMT providers, but we're creeping back up gradually to where we were. And as of this contract year, we have 2.5 million trips roughly that we're looking at. Next slide. So again, NEMT program consistency, one of the reasons that we have the TMSU is we try to cooperate and collaborate with the MCOs and their NEMT programs just to make sure that all of the NEMT programs have similar policies, similar guidance, similar requirements for members and meeting member needs, and making sure that there's reliable, safe, and on-time transportation across the board for members who need non-emergency medical transports. Next slide. This one really, it just gives a definition of transportation brokers, what they do. I talked about that earlier. But in the bullets down below, it's just essentially saying things that brokers need to do in order to make sure members can have access to the services. But brokers can provide internet access for requests for transportation services. Brokers are supposed to be available 24 hours a day, 7 days a week, 365 days a year, because we know trips occur in and throughout the year for all Medicaid members. And I don't know if we're providing a copy of this slide out to those participating, or this presentation, but it'd be good because on the next couple of slides, there are different contact point numbers. So next slide. So data and software, as you saw earlier, we keep track of the metrics, but we actually are just finished up with implementation of 100% digitization of our trips in the non-emergency medical transportation fee-for-service network. So, and most of the MCOs have also followed suit. So that means that we're able to track all of the trips, be able to see when they were delivered, when the services were completed, and track them real time, looking at the digital breadcrumbs that the providers leave. So if there are ever issues with transports, we can actually address them directly with the provider in and through the broker, and then get satisfaction for the member. Like if they're having regular issues with problems with a provider being late and not having good on-time performance, we can use all of this to address it directly. And if need be, work with the broker to assess liquidated damages against providers that are not doing what they need to for members. Next slide. Our TIMS is our Transformation Information Management Software System, and that's essentially what allows us to track all of this and to do it statewide. We can also do things like work with the broker to adjust rates. They can do things digitally to make sure that hospital discharges occur in a smooth fashion. So again, we're just bringing this up because we have a lot of software, we have a lot of data, and we can do a lot of different things in real time to make sure that the transportation for members is accomplished in a way that's satisfactory. Next slide. Sorry, next slide. Okay, so this is just a screenshot of our mode of care tableau and the database that we use in order to track things by region, but we can go by any date range and see roughly how many trips we have, see how many members, and we can go by member to figure out what their complaints were, see the number of complaints, and see where we need to hone in the particular provider network to make sure we address issues or problems. Next slide. So these are the slides that I thought would be very important for stakeholders to have access to and to be able to give to staff. But essentially, this is all of the toll-free telephone numbers, and we also have for the different managed care plans and their brokers. And on the next slide, I believe there's a, so this is for reserving and making trips. And then the next slide is for if they are looking for assistance with their transports. These are the phone numbers they call by broker and by plan to find right assist or get help with transportation issues that they may be having. Next slide. So in-state and out-of-state travel overnight. So there are questions that regularly come in from members that need overnight transportation or they need transport outside of the state in order to access care that's specialized and that isn't provided within the Commonwealth. So the important things to remember here is that for fee-for-service and MCO Medicaid members, all authorization has to be obtained before the travel begins. So that's either working with medical support unit here at DMAS or working with the appropriate staff at the plans in order to obtain authorization and determine that it's medically necessary to transport the individual or the member outside the state. What we essentially will do is once we receive an authorization letter, we can make arrangements for transport if needed, like to travel by train with an appropriate broker or provider that will provide stretcher transport if needed. We can do air, ground, ambulance, or we can work with, providers that work with members to address their specific needs for transport. For instance, if they need to go by train or airplane, we can do that as well. When we allow for per diems up to the GSA approved rate by region. So for travel, there's generally a smaller or half rate per diem, and then there's per diems per day for each day that you're out of state. And we provide reimbursements for those per diems, but also we'll reimburse for things like lodging, et cetera, according to that. Next slide. And then if you have questions, I know we're saving questions for a particular time, but if you think of questions, or if you're shy to ask during this presentation and you want to send me an email, you can either send it to the transportation email, or you can send it directly to me at my email, which is there at aaron.moore@dmas.virginia.gov. And yeah, I look forward to hearing from anyone that might have questions about NEMT.
We did get a couple. Oh, go ahead.
Okay, I was saying hopefully I didn't bombard people with too much information right now. So.
Well, I think you're amongst a group that is very happy to get a good bit of information that we could digest over time and come back and ask questions if necessary. We did get a question, how can we get a copy of the phone numbers? It looks like there were some revisions, and we typically send this presentation out with the booklet of all the information, and so it will be incorporated in that, so you should receive it. Is there, I know there was, somebody sent me a separate one, and this is for Lisa and Aaron. Are there any impacts to the services provided in your area now that they have switched over to, now that all programs are under the umbrella of Cardinal Care? I'll pose that to either one, and I'll start with Lisa, and then we can go to Aaron.
Yeah, thanks for the question. No, there should be, hopefully, I would hope that there could be some improvements felt by members. So behavioral health obviously impacts everybody, and people need all sorts of levels of support. And so moving from kind of two different groups, both of which, need the same services, maybe in different amounts, moving to the single model should hopefully help with care coordination for people specifically with behavioral health conditions, because it's more of a, different levels of care coordination depending on need. So it should hopefully lead to some smoother care coordination and no known impacts that we've identified. So we're really, really glad about it, and think it's going to be helpful for people with specifically serious mental illness or in early stages of mental illness.
Thank you. And what about you, Aaron?
Well, for transport, for fee-for-service, and for the MCO NEMT brokers, there really won't be much of a change. I mean, the benefits remain essentially the same under Cardinal Care. Transportation benefit is one of those CMS requirements where they talk about having a necessary access or link to the care that's being provided under Medicaid. So we don't anticipate anything being limited or eliminated with respect to transports as a benefit.
Excellent. We got a comment that said they hear from many families that wait times for transportation drops. That wait times they have when their transportation drops them off for an appointment, and then they are waiting hours after to get home. Some of these families have small children. The places can be burdensome, and return trips. How can stakeholders better support those families, understanding that you did mention a process for working with the MCO, the broker, in order to address some of those, more trending concerns, but in the immediate, is there any way that our stakeholders can support our members more when they're experiencing this?
Well, I think probably the best way to support members when they're having issues or challenges with transportation is, I hate to say it this way, but it's probably just to make sure that the complaints are registered regularly and that all the information is obtained by identifying who the provider is. Because if we know which providers are I guess you would say the regular violators or the regular problem providers, then we are able to address that, like I said earlier, with the brokers to assess penalties, and even if we need to remove a provider from network. Usually when you start impacting the financial bottom line of the providers is when you get to see a lot more better behavior. So submitting complaints, tracking where the problems and issues are. The other thing is when we receive a number of complaints from particular regions, we look at the network of providers and determine whether or not there's like an adequate network in that area. Because sometimes it's not necessarily that the providers aren't doing their job, it's just that there aren't enough of them to meet the transportation need within the particular area. And that can lead to extended wait times. So if you've got only 3 or 4 NEMT providers in a large region or in a large community, and you've got like maybe say 200 trips on a given day, it's going to take them a while to get through and work through all those trips. So but I mean, I hate to say, like, submitting complaints is probably the best way to support. The other thing you can do is contact the broker directly through those ride assist numbers and just say, hey, this family's been waiting for an hour. Can we get an ETA for their transportation provider? Sometimes if an NEMT broker is made aware that there's an issue in that respect, they'll escalate and they'll send out another transportation provider that wasn't assigned, but they'll just take care of it in the moment to let the families get home in a decent time. Hopefully that's helpful with respect to an answer.
Absolutely, absolutely. Another question for you, Lisa. When there's a lot of information being shared, a lot of wonderful resources being spotlighted in the mental health space at this point across the state, a lot of work that's happening for any of our stakeholders, how do they get involved with some of the work in order to best support what's going on? Or is it a process? Do they need to contact someone? How can they get involved in better support the conversation and the resources that are being shared?
Yeah, so I think right now the best way to do it is to get involved with the Right Help Right Now project. They're really trying to serve a coordinating role across not just Medicaid but all the state agencies. So that's going to be through this administration, so at least for the next 2 years. So why don't I put and they're often having events. They had a faith leaders forum not too long ago. So why don't I share that information, because I think at least that's sort of an ongoing question. But if you're already getting all the Medicaid bulletins and things of that nature, then yeah, I think getting looped in with Right Help Right Now is the best way to have an eye on all the different opportunities. So let me grab that.
Excellent. Next slide, please, Dahlia. And last question for both of you. When you think about the work, and you've been in the work a long time, what would be some really great advice that you have for our stakeholders in staying engaged in a positive and healthy manner with the information that's coming your way? Transportation is not always fun when you're dealing with stakeholders who have members that are constantly, which makes sense, having complaints or having issues or challenges with transportation. And mental health is something that can be quite sensitive when dealing with a family or a system or a network of providers. And so how do you stay encouraged, and what would you say to our stakeholders to have them continue to be encouraged in the work that they do in these areas?
I could let you answer first if you want, Lisa.
Sure. I think for me, I'm just always trying to remember, and I truly do believe that right now we're really just in a situation of, maybe it's always like this, but it really feels like unprecedented complexity. And it is just, things are so complex. And if we don't have that, just that ongoing dialogue, I say dialogue is, and of course I stole this from someone, but I don't know who, but the process of of folks communicating until there's nothing left. There's nothing left to talk about. There's nothing left but the obvious truth. And so that idea of just continually sharing information. There's truth to what everybody shares, and there's so many different complex things going on that without that open dialogue, we just don't stand a chance at solving any of these problems. And so that's what I tell myself, to stay motivated and stay connected, and just continue to get more and more information, because it's going to take all of us, and it's going to take all of us communicating openly for us to make progress on this.
Well, for me, I mean, to stay positive, and I know that NEMT services are regular points of contention and challenge. So it can be kind of a regular occurrence that people are not very happy with the service that's being provided. But to stay positive, one of the things I always remember is that NEMT is, in a lot of instances, the only connection that members have to access the service that keeps them alive and keeps them healthy. And I try to remember that I can actually, and my team can actually be a positive point in the experience to getting access to the service. So it's just one of those things to try and I try to always talk about this with respect to member service or customer service with my team, is just to remember to be empathetic and remember how you feel when you're right in the middle of trying to get access to a medical service and you're running into an obstacle. You know, could be for you, could be for your family member, but, you know, just trying to remain empathetic. We're thinking about your experiences and trying to say, I want to make this a better experience for this member than maybe I've had in the past. So sometimes, you know, individuals will come to the table with other things, other items, other baggage, and it's not just us that's making them upset. So I also try to remind my team that, you know, we don't know what people's days entail, what they have to deal with on a regular basis. We just need to be there and be positive and be helpful.
You can't shore up those words. So thank you both, Lisa and Aaron, for your time today, for your expertise, and thank you for dropping additional information in the chat, Lisa, about Right Help Right Now, and we thank you so much for all that you do, continue to do, and do in support of our stakeholders and advocates who are in this work every day. So thank you. So as we wrap up, we have a couple of announcements. And the thing that I did want to spotlight for the end of year is, yes, there is a recording. It would definitely be shared on Town Hall. That's where we typically place that information. And so all of that information will be on Town Hall so that you can access it afterwards if you want to come back to this information. And the next thing is, if you've had a win this year regarding Virginia Medicaid, it has been an interesting one. We've been going through unwinding, we've been going through all kinds of things in Medicaid. And so we always want to hear from our stakeholders about the areas in which are going well, went right, or those moments where you hit those light bulb moments where it's like, this is why I do the work. This is what's encouraging for me. So we would love to capture some of those stories and highlight them and share them with everyone. So if you have the time and you have the opportunity, please send them to us at covervirginia@dmas.virginia.gov. I'll drop the email in the chat, and we would love to hear from you regarding that. And then a couple of other announcements. If you go to the next slide, please, Dahlia. We have Medicaid MAC, which is a member advisory committee. We're very proud of this committee. It's an opportunity for our members to engage, get information, provide feedback to our director and other executive leadership team members. We've had speakers there. Lisa was one of our speakers recently, and they are a very engaging bunch with lots of questions that we love. And so we are in the process of filling 4 seats for that committee. In 2024, we're taking applications now. We really encourage you to encourage your members to apply to be on this committee. We are an example for other states because we've been doing it now for 3-4 years, and our members really love the engagement and the opportunity to provide that feedback to our agency in order for us to be better at what we do, to Aaron's point. And so the QR code is here. Please share it. If you want more information, we'll also include that information and follow up. Next slide, please. And so next year we will be continuing this journey of our stakeholder meetings starting in February. And so we have topics to choose from. And so in addition to you sharing your success stories for 2024, we would love to hear from you about what other topics you would love for us to dive into. I'll send out some additional information that allows for you to drop that in, but you can send that information at any time. You do not have to wait for us. If you have any here that you want to drop in the chat, we'll take them now. Any topics of interest to you, anything else we would like to anything else that we would like to discuss, please let us know. We're more than open and happy to consider it. So we want to thank you so much for your time this year and look forward to seeing you next year. So next slide, please. All right, so thank you all so much. There's the email address that you can send all this information to. We'll have a follow-up that includes the booklet with all of this information, as well as opportunities for you to connect for MAC and other information. So don't hesitate to grab that information. Thank you again for coming, and thank you for having patience. And we look forward to seeing you in the new year. Happy holidays. Thank you, everyone. Thanks, Lisa.
Thank you all.
Thanks, Grant.